come up or anything like that. Try to be interactive, but I know that's hard over Zoom. So just wanted to go over in general adult CF. So briefly reviewing the basis of CF, history, diagnosis, what makes adult diagnosis different, and then briefly review some treatments. And then if we have time, we can get into critical care issues specific to CF, but since we're starting late, might not be able to get to that part. So I'm sure you all are pretty familiar. So CF is an autosomal recessive disease, most prominent in the Caucasian population, but I think it's important to note that it is prevalent in other populations as well, and it's important to think of in non-Caucasians as well. So the history of CF, was first identified in the 1700s. There was a children's song about the child who tastes salty. And actually, I think it's interesting. One of our patient's mothers told me that that's how she diagnosed her child. When she would kiss him, he was salty as a child. And then in 1938, it was first identified in the pancreas as fibrocystic disease of the pancreas. So that's why it's called cystic fibrosis. And at that time, life expectancy was less than a year. And then the real breakthroughs came in the 80s when the CFTR gene was first identified. And that's led to a lot of, later in the talk, we'll talk about new modulator therapies acting specifically on the CFTR site.
Okay, thank you, Michelle.
So I think one of the things that makes the cystic fibrosis and a lot of the advancements in care with cystic fibrosis different is the CF Foundation. So I think it's important to point out that was started in the 1950s. They created this database where all accredited CF centers register all their patients with their consent to monitor these patients. So we've got 50 or 60 plus years of data on all these patients. So that's helped with a lot of the longevity and care. They work with the accrediting, and they also pioneered this thought of venture philanthropy. So the CF Foundation actually does a lot of fundraising and does a lot of support to the pharmaceutical company Vertex, which has created a lot of the breakthrough drugs for cystic fibrosis that we'll talk about the modulators. So the CFTR gene, it's a chloride gene. It's on the apical membrane of epithelial cells in the lungs. So chloride does not get into the lungs and creates this really thick mucus. And then that's that gene. So I think this slide is very important. So talking about the different types of mutations within cystic fibrosis. So we talk about what class of variant. So in group 1, cystic fibrosis, so no functional protein is made. And so this is where you're going to see a lot of your non-Caucasian patients who have different mutations. Group 2 is what we think about with our classic Delta F508 patients that I think most of you have probably heard about. So what happens is the protein is made, but it doesn't fold, so it doesn't traffic appropriately to the cell membrane. And then group 3 is notable. So this protein makes it to the membrane, but doesn't function. And then group 4 is less function. Group 5 is less protein made. But group 3, I think the other thing to point out, so this is where the first modulator therapies were identified in the G551D population that improved the chloride channel function. So group 3 mutations and group 2 mutations are right now the ones that are eligible for modulator therapy. And the quantity of CFTR function correlates with symptoms. So the higher the sweat chloride or the less CFTR function, the worse disease manifestations. And this is all definitely regulated by modifier genes too, but in general, this is a good rule of thumb. So classic CF is disease of multiple organ systems, a sweat chloride greater than 60. However, in most of our adult diagnosis patients, you're going to see more non-classic, so indeterminate sweats, a wide spectrum of disease. So it's a multi-organ system disease. So both tend to have sinus, all pretty invariably have pulmonary involvement. GI involvement is more of a classical cystic fibrosis finding. Kidney stones, specifically calcium oxalate stones. And then for males, obstructive azoospermia, so male infertility. And then female infertility to some extent because of thick mucus, cervical mucus, but that's more variable. So indications for sweat testing. Anytime you have a suspicion, specifically in adults, you're looking for people with persistent pneumonias, specifically if they have staph or pseudomonas and evidence of bronchiectasis on imaging. And then in the pediatric population, rectal prolapse, nasal polyposis is something that you'll see in adults as well. So if they have a lot of sinus disease, that would make you think about cystic fibrosis. The other thing that I think as pulmonologists, we don't necessarily always ask about routinely is GI symptoms, but specifically when you see a constellation of bronchiectasis with GI symptoms, that should start ringing bells about cystic fibrosis. So sweat chloride testing was first developed in the 60s. It's a difficult test and it's not done routinely at all labs. So you want to make sure that when you're ordering sweat chloride testing, that it's done by a center that does it routinely. So here at Inova, we do it, and they only do it on 2 days a week. So it's Tuesdays and Thursdays. And basically they wrap the arm in plastic and stimulate the body to produce sweat, and then they measure the amount of salt in that sweat. It's important to think about specifically relevant. So if patients are on steroids, so if you're thinking about your bad asthmatic that you're referring, that can create a false low. So if they're in that indeterminate range, you might try and wean them off and repeat testing. Also, if they've got hyperproteinemic edema from, some type of GI disorder or nephrotic range proteinuria or something like that, that can also affect your results. Other conditions, so hypothyroidism, malnutrition can also affect your sweat chloride test. And this is an example. So you see there's little plastic rack and little stimulators on the kid's arm, and then they collect the sweat from underneath there. If that's not definitive, nasal potential difference is also something that can be used. There are only a few centers that are validated to actually do nasal potential difference. I believe the closest one to us is Hopkins, but hopefully you can get a diagnosis through genetics and sweat chloride and clinical suspicion as well. But one of the things to consider with nasal potential differences is the presence of nasal polyps or inflammation can create a false negative too. So genetic testing. So there's a basic 23 mutation screening panel that is commercially available through all the major labs, Quest. But this only identifies 90% of CF causing mutations. So if you have a high suspicion, there is gene sequencing that can be done that we send labs off to Hopkins to get full gene sequencing. But even if you have a high suspicion and 2 mutations aren't identified, that doesn't necessarily exclude a diagnosis of cystic fibrosis. Additional testing to consider. So if your patients do have GI symptoms, screening for pancreatic insufficiency. So the easiest way to do that is a fecal elastase, which is a one-time measurement of stool. There is 72-hour fecal fat collection, but collecting your stool for 72 hours, I'm sure we all realize that could be problematic in itself. And then there's direct GI sampling that can be done. But again, you have to find a GI who's comfortable with managing these things. Other things that you want to consider are excluding contributing diagnoses. So specifically testing for immune deficiency, looking for evidence of ciliary dyskinesia, and that would affect your distribution of bronchiectasis because a ciliary dyskinesia is more basilar bronchiectasis, whereas CF tends to be more of an upper lobe bronchiectasis disease. So diagnosis, since I believe the 70s, all states have some form of newborn screening. And so you can see a lot of patients with cystic fibrosis will be identified in childhood, but there are still going to be these groups of either atypical mutations or non-traditional presentations that are going to slip through to adulthood that haven't been diagnosed. And then speaking more specifically about adults, so the population, I think a lot of people in the community still think of cystic fibrosis as a pediatric disease, but over 50% of the population of people with cystic fibrosis in the US are adults now. And that number is just going to continue to grow as we get better at treating these patients and having increased survival, as well as there's increased recognition of these milder phenotypes in adult diagnosis. So I believe this inched up to 45 most recently, but this is the average lifespan of patients with CF. And you can see it's been growing. And I think with the recent introduction of Trikafta in 2019, we're going to see this number go up even higher over the next couple of years. And so why is adult survival better now? This diagram kind of goes through all the different things that have contributed to the improvement. So started with GI supplementation, then antimicrobials in the 60s, then inhaled therapies and airway clearance. And then most recently, as of 2012, was when the first modulator therapy was first approved by the FDA. So that's made quite some leaps and bounds in survival in the CF community. And then also this translates into better lung function as people age through with these new therapies being added. And then in general, most of these people are very functional. Over 50% have full-time jobs. So these people can live a normal life as long as we can help them keep their disease under control. So adult diagnosis, the oldest reported age at diagnosis was 81. So it's never too late to think about cystic fibrosis as part of your diagnosis. And then I think we already touched on this a little bit. So specifically adult diagnosis. So if you have a sweat chloride greater than 60, that's definitive for cystic fibrosis, 2 identified CF mutations, or if you have an indeterminate a sweat chloride and 1 CF causing mutation, then that could be a diagnosis. And I believe the lower limit has actually decreased at 30. So between 30 and 59 is considered indeterminate now. I'm going to skip through this a little bit to get to the higher related points. So cystic fibrosis related pathogens, you can see Pseudomonas becomes one of the most dominant pathogens, but more so through the adolescent age. So most of our adults are colonized with cystic Pseudomonas. And then Staph aureus is the other big pathogen from childhood to adulthood that are the most common bugs that you'll see with patients with cystic fibrosis. So going into treatment. So I think the most important thing is to recognize that there are a lot of different components and these patients are managing very complex regimens. I think from the inpatient side of things, having somebody who's familiar with diagnosing and dosing cystic fibrosis medications, because cystic fibrosis patients tend to have a higher volume of distribution. So antibiotic dosing, I don't know if you guys remember on the morning meeting, Dr. King talked about how the patient was getting a lower dose of meropenem than what is recommended for patients with cystic fibrosis. Because of this higher volume of distribution, to actually saturate the tissues, they need a higher dosing. So you want to make sure that you're dosing appropriately for cystic fibrosis. And then other things, so pancreatic enzymes, these are typically not necessarily at every hospital. Typically most places have Creon, but some of our patients will be on other enzymes. So talking to them about having their own, making sure you're supplementing fat soluble vitamins because there's fat malabsorption with the pancreatic insufficiency. Nutritional supplements, because weight is something that we harp on extensively, and I think I'll talk a little bit more about that. And then being aware of treatment of constipation or malabsorption, because patients can often report normal stool, but just like the mucus in their airways is sticky, their stools tend to be stickier. And so having occult constipation causing a lot of GI issues is something to be aware of too. So I think one of the bases, if you take away nothing else from this talk, is that airway clearance is very important for bronchiectasis patients. So it's just like if you have a biofilm that's constantly sitting in the airways, that cycle of infection, inflammation is what really drives the worsening and the progressive nature of cystic fibrosis. So really having a basis of good airway clearance to clear those biofilms is really important. So different medications that are used, hypertonic saline. So we use either 3% or 7% in our patients, depending on what they tolerate. At the higher 7%, some patients don't tolerate that because of bronchospasm. So they need 3%, but most of our patients can tolerate 7%. Dornase. So you can see this is an example of Dornase. So this is how thick the mucus is without any kind of Dornase being used. And once you've added Dornase to the mucus, it makes it much thinner. So it cleaves those DNA bonds, makes it easier for the patients to expectorate that mucus. And then inhaled antibiotics. So airway clearance. Making sure patients are doing appropriate airway clearance is a big fundamental. So having a respiratory therapist or somebody take the time to go over proper airway clearance with patients is very helpful. So there are multiple different types of airway clearance. Postural drainage, which is demonstrated down here, actually laying in different ways to help clear the mucus with gravity. This is a vest, which a lot of our patients use. So it's fitted specifically for the patient, and it really just vibrates the patient to help loosen up those secretions. I'm sure you all are familiar with these flutter and acapella valves. So the cucumber is what a lot of patients will call it. And then manual percussion is another thing that if they have a dedicated family member who's been trained to help loosen those secretions. Exercise, I think, is something that we always harp on as well. So sometimes we can tell patients that they can substitute an airway clearance session with a good session of exercise to help clear those secretions. And then huff, cough, and expectoration. So huff, cough is basically a segment of breathing that increases your intrathoracic pressure to eventually help expectorate those secretions. And so this is just another, the benefits and the mechanism. So I think especially when you think about patients in the hospital, we use a lot of vest therapy and a lot of manual percussion. Patients who are more mobile and active, the acapella or flutter might work better. And then the cough assist device, so not really used in CF, but is more for patients with neuromuscular disease. So that actually creates a negative pressure effect and helps draw out the secretions. And then the IPV is more through vents. So it causes just oscillations, which in the airways. I think the other thing when you talk about patients with your airway clearance, you want to make sure that they're doing the appropriate range. So this acronym Be Happy, I think, is helpful. So you want to make sure they start with the bronchodilator because these medications can be bronchospastic. And then you want to make sure that they're doing their inhaled antibiotic the last, because you want to make sure that stays in the airway. And the same thing with the inhaled corticosteroid, because you want to make sure that stays in the airway before they use these treatments to help clear out the airways. And I think it's also important to remember how much we're asking our patients to do, because an average treatment can take 1 to 2 hours if it's done appropriately. And so if we're asking our patients to do that 2-3 times a day, I can't imagine trying to fit that into my schedule. So just being cognizant of what we're asking our patients to do and stressing the importance is helpful. So airway clearance by age. So you can see most people still use the vest, and then the PEP valves are used more frequently too. And then anti-inflammatory agents. So I think a lot of us are familiar with using azithromycin for chronic Pseudomonas infections. And so the data in COPD has been translated, but it started with patients with cystic fibrosis. So using in patients who are chronically colonized, chronic azithromycin has been shown to improve FEV1, but that benefit tends to drop off once the patients are stopped. Pancreatic insufficiency. So it's important if you've made a diagnosis of CF to make sure, even if patients report normal digestion symptoms, to consider pancreatic insufficiency. One of the key points to remember is it's a decreased secretion of bicarb, so they have more acidic GI contents. So oftentimes they require a PPI or an H2 inhibitor to increase that gastric pH or de-acidify the pH that's going into the duodenum to allow optimum effect of the enzymes. So talking to your patients about if the enzymes don't seem to be working, considering an H2 blocker or PPI. And then typically if patients have pancreatitis, that means they're pancreatic sufficient, but with repeated bouts of pancreatitis, they can become pancreatic insufficient. So keeping an eye on those symptoms. And then DKA is typically rare in cystic fibrosis because they don't have glucagon secretion as well. So patients can have CFRD, but one of the things to talk about with the endocrinologist or the primary care who's managing patients with CF diabetes is that we don't want to restrict their diet, and that continuing carbohydrates in the diet is important because of their nutritional needs, and they're at lower risk of DKA. Pancreatic sufficiency, so you can see that it's typically decreases as age goes up. So other complications, I think, especially to consider as more and more patients with cystic fibrosis are living to adulthood, is other diseases. So reflux is a very common comorbidity, often because of increased cough. They have flattened diaphragms from hyperinflation, delayed gastric emptying from diabetes, and then the medications that they're using. And then looking for hepatobiliary disease, I think depression and mood disorders is something that's also very important to screen for, and that we screen on an annual basis with our cystic fibrosis patients. Any kind of chronic disease population is going to be more prone to depression and anxiety. And then bone disease, so we get yearly recommend DEXAs to screen for osteoporosis, specifically because of that vitamin D malabsorption. And then cystic fibrosis related diabetes. So A1Cs are less accurate in patients with cystic fibrosis because of the turnover. So actually recommend yearly oral glucose tolerance testing to screen for CF related diabetes in patients with cystic fibrosis. And so it's important to screen. So when typically we think of the classic symptoms of polydipsia, polyuria, but in patients with CF, when there's a drop in lung function or a drop in weight, you also want to think about cystic fibrosis related diabetes. And the reason we harp so much on weight is because weight tends to correlate with your FEV1. So you can see the optimal BMI recommended by the CF Foundation for women is a BMI of 22, and for men it's a BMI of 23. So whenever you see patients with us in clinic with cystic fibrosis, we always talk about weight, what's their ideal weight, and talking about their ways to optimize their nutrition to keep them in this optimal BMI. Now, a lot of that is changing with new modulator therapies, and we're actually having the opposite problem where patients have developed these habits where they're allowed to eat whatever they want, and now they're actually having issues with obesity. So it's really finding that sweet spot. And so this is, I think, what I touched on a little bit. With patients with CFRD, you never want to restrict their calories or their carbohydrate intake. And they typically have a higher fat intake. You do not want to reduce their protein. And then you want to make sure they stay on a high sodium diet. And a lot of this is, I think, going to change. So I think you've heard me mention a lot the CFTR modulator. So this is beginning to talk about that. So the first CFTR modulator was approved, ivacaftor, in 2012. And this was only for those group 3 mutations, the G551D mutations. And now this drug has been approved down to age 6 months. And then most recently, which isn't on this timeline, is in November of 2019, Trikafta was approved. For all group 2 mutations. It's actually just been opened up. So it started with just Delta F508, but now it's been opened up to many more mutations within that group too. So it's available. And I think one of the things to consider is, especially making the diagnosis in adult patients, is some of these mutations are associated with adult diagnosis, so we can really benefit these patients from modulator therapy. And so you can see the progression of people who can benefit from modulator therapy has definitely been increasing. And now 90% of patients are eligible for Trikafta. So it's important to think about when you see a CF patient are they eligible for modulator therapy, and are they on modulator therapy? So that kind of gets to that point too. So when you're talking about the different modulator therapies, so ivacaftor is, we call a potentiator, because if you remember in the group 3 mutation, the CFTR chloride channel makes it to the membrane, but it doesn't function appropriately. So ivacaftor improves the function of the CF channel and increases the amount of chloride that's transported through that channel. So kind of putting it into perspective of all the other therapies we've talked about, the inhaled airway clearance, the azithromycin, the percent change in FEV1 for these modulator therapies is on the order of 10 to 15%, whereas these other therapies improve maybe 3 to 5%, some up to 8% for inhaled antibiotics. So it's just a bigger bang for your buck with the modulator therapy. Then I'll kind of go through these a little bit faster, but so lumacaftor is not really used as much anymore. Orkambi was one of the first modulators for the patients with Delta F508. There were some side effects in patients with severely low FEV1s that they would have bronchospasm, but most of our patients have been transitioned off this. So we're on Symdeko. So it's tezacaftor, which it helps increase the amount of functional protein that's produced. So it's a corrector of the protein malformation. And then the most recent, so elexacaftor, tezacaftor, ivacaftor, has improved things significantly. So you see on the realm of things, so it decreases your sweat chloride by approximately 40 points, improves quality of life, and improves FEV1 on that 10 to 12% range. And so when you take a look at that, and this is available for over 90% of patients at this point. So this is one of our patients. Because it's a corrector and the CF chloride gene is all over the body, he sent us pre-Trikafta. This is a sinus. So you see there's a lot of mucosal thickening, had a lot of sinus issues, and then this is post-Trikafta. So his sinuses have really clearly opened up. So works all over the body. So improves GI symptoms, improves respiratory symptoms. And so other considerations, kind of shifting gear. So transplant, when would you consider transplant in patients with cystic fibrosis? And I think a lot of the hard part for people who don't routinely take care of patients with cystic fibrosis is that they can often look very well until they get very sick. So recommend starting to consider the transplant evaluation if their FEV1 is less than 30 to 40%, any kind of oxygen requirement, any evidence of hypercapnia or pulmonary hypertension. Cystic fibrosis patients tend to do better post-transplant, mostly because they're young and they're used to handling complex medical regimen. So the average post-transplant survival for patients with cystic fibrosis is higher than our average 8 for other people. It's more on the 9 to 10 year range. And then this is also consistent with patients with resistant bacteria. Couple of things to consider. So, and these are typically on the boards too, is Mycobacterium abscessus and Burkholderia cepacia, particularly Genevar 3, are considered contraindications to transplant in patients with cystic fibrosis or patients in general, because they are so resistant bacteria. So it's important to make sure you're screening for this. And with our patients, we routinely get sputum cultures at every visit, and try and get AFB cultures at least yearly. So common things to consider about candidacy that we can try and work on with patients. Again, going back to undertreated anxiety and depression, chronic opioid use. So a lot of patients have chronic pain related to chronic cough and chest pain. Want to screen for comorbid CF liver disease. Malnutrition is a big issue. So a lot of times patients need nutritional supplementation, either with supplements or sometimes needing PEG tubes to get nocturnal feeds or other additional protein supplements. We want to make sure their CF related diabetes is well controlled, and then screening for other GI issues. So looking for gastroparesis, making sure they're on a good bowel regimen if they have a history of dios, and then always considering their altered absorption. So even if you're not a CF doctor, these patients, if you're going to be in the ICU, will show up to other non-CF centers. So most of them are admitted for respiratory failure. Hemoptysis is another major involvement. I think even considering that these patients are chronic patients, so families are involved throughout their life. So making sure the families are involved, and oftentimes they'll be able to give you a better history of what the patients are on, what kind of bugs they've had, what things work for them. So typically when we treat CF exacerbations, you treat for longer than the normal pneumonia, and it's usually 14 to 21 days. And that's another point. It's not typically pneumonia per se, but even bronchiectasis exacerbations, which might just be increased sputum, but not necessarily a discrete infiltrate on imaging, would still warrant treatment with antibiotics. You often want to treat with 2 complementary antibiotics. So a beta-lactam and an aminoglycoside or whatever based on previous sensitivities. Remembering this higher dose of antibiotics, so factoring in that higher volume of distribution and rapid renal clearance. And then you want to make sure that you're incorporating chest PT and airway clearance even in the hospital, typically 3 to 4 times a day when they're admitted. And so what is a pulmonary exacerbation? So any increase in sputum, weight loss, any drop in lung function, fatigue are typically the things that will trigger us to consider an exacerbation and need for antibiotics. Less frequent fever, shortness of breath, and then hemoptysis. So it takes a lot of people to help take care of patients with cystic fibrosis. So you want to make sure you're doing your airway clearance, so you've got good respiratory therapy support, you've got your antimicrobials, dietary support to make sure these patients are ordered for regular, we do double portion meals, high fat meals, and have snacks, and you want to make sure that they have their enzymes available so that they can actually absorb the food that they're eating as well. Physical therapy for airway clearance as well as maintaining strength, and then good respiratory support for their oxygen support. Other things to consider, so sepacious syndrome. I know we're all very familiar with 6 feet apart now with COVID, but that started in the cystic fibrosis community where they used to have CF camps in the 80s, but then they found a lot of the children were passing away and getting these bad infections from Burkholderia cepacia that was passed through respiratory droplets at these camps. So that no longer happens. And it's recommended that all CF patients stay away from other patients with CF 6 feet because of the risk of spread of these bacteria. So sepacious syndrome specifically causes a rapid decline in lung function, and it's very high mortality and can cause sepsis. Whereas other bacteria that cause exacerbations like Pseudomonas and staph are much less likely to become systemic infections in patients with CF. You want to try and avoid intubation as much as possible because once patients get on the ventilator, airway clearance is definitely much more difficult. So we often consider non-invasive ventilation. It's important when you think about these patients that they typically need a full face mask because sinus disease impairs flow through the nose. So you want to incorporate their mouth too. Other things, so major hemoptysis, remember we said that they had decreased absorption of fat soluble vitamins, so you want to make sure you correct any coagulopathy from vitamin K deficiency in their diet. You always treat assuming that they have some type of underlying bronchiectasis exacerbation, so treating with it antibiotics, and typically we hold chest physiotherapy for at least 24 to 48 hours until the hemoptysis has resolved, if there's major evidence of hemoptysis. Often these patients will need bronchial artery embolization because they have big tortuous vessels. And I don't think I have it in here, but Dr. Brown has a good picture of an explanted CF lung with very, very dilated bronchial vessels from this chronic inflammation that causes and then chronic inflammatory cycle with these dilated vessels can predispose to hemoptysis. And then transplant evaluations. So a lot of patients who have cystic fibrosis who've undergone transplant are at higher risk of pleural adhesions and risk of post-op bleeding because of those adhesions and the very irritated pleura. Other extrapulmonary things to make sure you want to keep an eye on is keeping a good bowel regimen for these patients. A lot of these patients will have abdominal pain come in. It will look clinically like an appendicitis, but ideally, if they're a patient with cystic fibrosis, you want to treat conservatively, trying to avoid surgery at all costs because it becomes a big mess. It's very sticky, high stool burden, high risk of infection post-op. So you really want to try and treat non-invasively with aggressive laxatives and try and avoid surgery at all costs for these patients. Other things to look for, so hepatic involvement. So ursodiol is used to thin those biliary secretions. Pancreatitis, if they're pancreatic insufficient, your pancreas isn't working, so it's unlikely to get pancreatitis. And then intussusception is more in the pediatric population. So this is dios, like I mentioned. So big things that predispose are dehydration, narcotic use, and then the fat malabsorption. And so treat with the osmotic laxatives. And then other things to consider. So with the pancreatic insufficiency, if patients are intubated, it's important to involve your nutritionist because there are different enzymes for tube feeding. And actually patients who are on home tube feeds, we actually recommend to bring in their home enzyme cartridge that goes in line. And then they need a higher energy requirement. So those are other things that are important to consider when these patients are in the ICU. So what's the major cause of death for these patients? So it's respiratory failure is by far and away the biggest problem that we have with patients with cystic fibrosis. So I think I kind of zoomed through that, but really I think looking and being familiar with these patients, talking to their primary cystic fibrosis team and identifying patients who you suspect of having cystic fibrosis so that you can prescribe them appropriate therapies, specifically in this age of modulator therapy, identifying patients, and then providing genetic counseling and screening other family members is really important. So in general, I think I want to impart that this is not just a disease of children anymore. Adult diagnosis should be considered, and went through some of the therapeutic implications that are a little bit different than other patients with bronchiectasis. And I know I went through that quickly, so please feel free to ask questions.
Hey, Anju, this is Kumar. Thank you for the talk. This was very informative. Some of these patients back at our institution see if they get a lot of pneumothoraxes, and we always have this question there if we should do pleurodesis because that will impair their chances of getting a transplant. So what do you guys do here? Do you do pleurodesis patient, or we just leave them as it is and then consider transplant down the line?
So with recurrent pneumothorax, there is a high risk of recurrence. So we do pleurodesis. I haven't seen that many who have had recurrent pneumothoraxes who've needed it, but iodine pleurodesis, per our surgeon, Dr. Tang, seems to be less of an issue post-transplant, but patients who have had pleurodesis can still get transplanted. It just makes the surgery a little bit more technically difficult, and they are at higher risk of bleeding afterwards. But I think the risk of recurrent pneumothorax kind of outweighs that. So if it's necessary, I wouldn't say you should not pleurodese a patient.
Oh, thank you.
All right. Well, if you guys feel free to track me down if there are any other questions, or if there anything else you wanted to talk about in particular. Otherwise, have a good afternoon.
Thank you.
Thank you so much. Have a good day.
Anju.